one of the more high level data that I think that from what I've been able to understand is really came out of in 2024 out of Hong Kong was kind of a phase 3 randomized trial, which we'll go into in a second. But before we talked about these kind of level one evidence for the use of en bloc TURBT, what evidence kind of drew you to kind of started using this technology and using this technique to be really for your patients?
Yeah, like why I was an early adopter.
Yeah.
So I've had a long interest in understanding the field effect versus reimplantation philosophy in bladder cancer. Like, why are we having so many recurrences? And from reading a lot of basic literature, I've come to the conclusion that I think that predominantly one of the drivers of recurrence is reimplantation. And that's something I kind of feel strongly about after my review of the literature.
Mm-hmm.
And based on that, I thought, okay, how can we effectively start to intervene to avoid that? It seemed to me en bloc was reasonable. So then I started to go into the en bloc literature, and I started to see that there are a lot of benefits to en bloc resection. Some of them we talked about briefly already. 1, there's lower risk of perforation. 2, there's no obturator reflex. 3, there's lower risk of bleeding. 4, lower need for CBI. And I think 5th, which is the most important, is you're getting the tumor out in one piece, so you get margin status. So if you tell your pathologist, hey, I took this out in one piece, tell me what's going on at the margin, they can tell you there's tumor at the margin, there isn't tumor at the margin. I think that's really powerful because now you're not taking everyone for a mandatory re-TUR if they're high-grade T1. That's a big deal.
Yes.
And the second big piece is when you morcellate a tumor, essentially what we do when we do a TURBT, you now give the pathologist all this de-oriented tumor. So they don't know where the edge is, they don't know where the base is. And so when you really dig into literature, you see that we're actually fairly inaccurate as a pathology field at accurately staging patients. Like we might call muscle invasive when it isn't there. We might call non-muscle invasive when it is actually there. And that's what's driven these high rates of re-TUR. We know that 1/3 of high-grade T1s, if you re-resect them, you'll have multiple disease.
Yeah.
And so that to me seemed like a place where we could improve. Like, why are we re-resecting everybody routinely if we can't just figure it out? So that early data, the pathology improvement was the big driver for me. And then I expected that there would be a benefit in terms of oncologic control, but it hadn't been shown yet. And that's where there was some, hesitance.
Sure.
Couldn't go around advertising that yet.
Yeah. So, I mean, just to go back on what you're saying, when you're saying that, it's in my practice, I assume it's the same for you. And this is per really NCCN AUA guidelines. If you have T1 high-grade disease with no muscle present, the recommendation is to do a repeat TURBT because, somewhere between probably 20 to 30% of patients have, muscle present that may be invasive in the next TURBT. So what you're saying is maybe you're sampling that muscle better and maybe it's more oriented so the pathologist is able to kind of understand the exact layers. Is that kind of what I'm hearing? Is that why you think this may be a better use case?
The rates of muscle and specimen for en bloc resection are universally in almost every study much higher than they are with traditional TUR.
Yes.
That's just because of the way you do the operation. You get below the lamina and you're just literally shaving off the muscle where it inserts on the lamina. So you just get like a whole piece of tissue. It's just a much easier thing for pathologists.
Yeah.
You're going them to fail.
I think I've seen one of your videos, and I think at least the videos you posted, I think in the past, you've used laser, I think, in order to do this. Is that right? Yeah. And I'm sure you've used multiple techniques, but when you use something like laser or even Collins knife, right? So how are you getting hemostasis after you end up removing this tumor from the bladder?
Yeah, I wish I had. I just did a case last week, and we had some bleeding, and then we cauterized it with the laser, so it would have been perfect to show you. I'll edit that and I'll post it on Twitter. But so different techniques result in different risk of bleeding. So when you do it with a laser, you actually really don't get much bleeding afterwards. I almost never having to do hemostasis after I get the tumor off.
Okay.
But if I'm going to kind of walk you through the procedure, if you have, like, let's say your tumor is like, let's say my fist, right? First thing you do is just take your laser and just score all around it circumferentially. And you do that all the way down past lamina propria to that muscle lamina propria junction. And then now you have this thing scored, you distend the bladder and the muscle's going to kind of stretch and that opening will spread a little bit. And so once you get that spread, you just undermine a front edge. So like, let's say let's like pretend we scored all around here. This is the front leading edge of the tumor. We now underscore this front edge with the laser and it starts to lift a little bit. Then you just use the beak of your scope. Anyone who's familiar with doing like a HoLEP will kind of understand what I mean. Use the beak of your scope and just scrape it up. And now you're holding up the tumor with the beak of your scope and your laser is just sitting right there at the crotch where the muscle scratch. So you just go beep, 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 and you fire your laser like this, and then you roll the whole thing off.
Okay.
And as you do that, you'll actually see like these perforating vessels coming up. And if
Mm-hmm.
you force it, you'll tear the vessel, it bleeds, and you have to go sit on there and just bring your laser closer and closer and closer till it heats up enough and it burns it, essentially cauterizes it.
Yeah.
And if you don't tear it, you can see it in time, you can just burn it before you ever go through it. So you actually get very little bleeding if you're doing an en bloc procedure sort of correctly.
I see. Okay.
With a Collins knife, it's the same. It's very like a Collins knife or a loop. It's the very same thing. Just take that Collins knife. Now you have a tip. You go boop 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 all the way around. Essentially hot the entire time on a cut current. And then I'll usually flip the Collins knife upside down to undermine the front lip. So boom boom boom, undermine the front lip. And then I'll take the Collins knife and turn it sideways. And those kind of arms on the side of the Collins knife like this will act as the wedge to push up the tumor. One pushes down the bladder, one pushes up the tumor.
Sure.
And then I'll move the instrument across like this, the blade of the knife this way, and I cauterize as I go.